This is John Berdahl, and thanks for joining us with iTube Daily Coverage, and I'm here with Enrique Barragán. And thank you so much for your great talk on small aperture IOLs. Give us a basic overview, and then I'll ask you a couple questions.
Thank you, John. This is amazing technology. We have the first cases done close to 3 years ago, and the depth of focus of this IOL is great. So we do a cataract surgery as regular does, remove the cataract, put the IOL, and the great thing is we don't have to worry about centration. So the patients the day after start with the wow effect.
So let me understand. This is basically regular cataract surgery with an IOL that's got a smaller aperture and it blocks light outside of that, helping increase depth of focus.
Correct. You're correct. The total mask dimension is 3.5 millimeters. The small aperture is 1.3 millimeters. So they give you a great depth of focus.
Tell me a little bit about your experience with it and what kind of results you've been seeing.
Well, 3 years ago we started with the proof of concept. So we are allowed to do 20 cases. At that time we have a silicone IOL, again for the proof of concept. Now we're using acrylic IOL. And we have 20 patients, 20 eyes, and they are very satisfied with distance, intermediate, and near.
So you're getting distance, intermediate, and some near, a lot of near?
Well, our target refraction has to be -3/4. So when you choose your IOL power, it has to be -3/4. If you got that, you will have 20/20 intermediate, 20/25 distance.
So I really enjoyed your presentation, and one of the more compelling things to me was how forgiving it is because you have more depth of focus. So if you do miss your target a little bit, unlike multifocal technologies, you're still probably going to be okay.
Yes, this is quite nice because the depth of focus, as you said, it is very forgiving. So you can be off target just above or under correction, and you will still have very good effect.
You know, one of the things that we've always worried about is glare, halos, decentration, nighttime vision, and the ability to see the peripheral retina if you've got a constricted thing. Are you seeing any of those concerns in your early studies?
Yeah, we were aware of, as you said at the very beginning, for me like a surgeon, in my very first 5 cases I was aware about centration because this is a pinhole or small aperture IOL. So the good thing is we just do the cataract surgery as we always do. We put the lens, rotate the lens 360 degrees and leave it there. And the surprise was the day after we have a really nice effect. Doesn't matter where the small aperture ends. And I have one particular case that has some fibrosis on the IOL displays. And the patients still remain from months number 3 to months 12 with a very nice visual acuity. So yes, it's very forgiving as the same as refraction from centration. The other thing is halos and glare. For the pinhole effect or the small aperture effect, most of those disappear. So what I'm saying is comparison with the small aperture IOL with the fellow eye has regular IOL, we have the same or even lower glare and halos. So that's really nice for the patients. They complain from the fellow eye has a monofocal IOL than from the small aperture.
And can you still see the peripheral retina?
Yes, we were aware about that. So we do a lot of tests. We do visual fields. We took some photographies as you saw in the presentation, and you can see the peripheria, you can see the macula, you can take photos of the optic nerve, you can still do visual fields.
And last question, do you anticipate this will be unilaterally implanted or bilaterally implanted?
Well, I do have one patient has bilaterally. Harry Carter asked me about if one is so good, why you put 2? And the answer of that question is, well, the patient demands. If the patient has the very first eye with the small aperture IOL, and then when he developed cataract in the fellow eye, says, are you going to put the same IOL that you did on my first eye? And I said, well, you know, we didn't think about it. And the guy said, well, this is my first eye is so good that I don't deserve less. So we went to with the fellow eye with the same IOL, and he's totally functional, day and night, drives, spectacles free. So I would say the good news is one eye is good enough, but if you have 2, it's way better.
Yeah, very good. So it sounds like a very forgiving technology, very effective technology. Thank you guys for joining us for iTube Daily Coverage. I'm John Berdahl.